Welcome to today's deep dive. We are really thrilled to have you joining us for a close look at a pretty compelling single source we have on the docket today.
Yeah, it's an excerpt from a recent phase 3 medical trial. Specifically, it's titled Finerenone Efficacy in Type 1 Diabetes and Kidney Disease.
Right, which is pure, unadulterated medical research. I mean, it offers a really rigorous look at a highly specific patient population.
Oh, absolutely. The documentation is exactly as dense as you would anticipate for a top-tier clinical trial.
Uh-huh.
It is heavily weighted with statistical analyses, precise demographic breakdowns, and the kind of complex pharmacological data that really forms the bedrock of modern evidence-based medicine.
And our mission for this deep dive is to basically synthesize that dense, number-heavy trial data. We want to extract the core clinical narrative for you.
Yeah, because hidden within these highly specific parameters is a very clear story.
Right, a story about a potential new treatment pathway for adults who are managing the dual diagnosis of type 1 diabetes and chronic kidney disease.
Or CKD, as we'll probably end up calling it.
Right, CKD.
And parsing this data is incredibly valuable because behind every p-value and geometric mean ratio, there is a methodical effort to understand how we can better manage these overlapping progressive health conditions.
Definitely.
Clinical trials of this magnitude are the gold standard for moving theoretical pharmacology into real-world standard of care protocols.
So whether you are a nephrologist or endocrinologist catching up on the latest literature, or a clinical researcher prepping for a discussion on trial methodology.
Or even if you're just insanely curious about how clinical trials actually work.
Exactly. If you're simply someone who follows medical science and wants to understand how drug efficacy is proven at the highest levels, this deep dive is tailored for you.
We're going to break down the numbers so they actually make sense.
Right, and more importantly, highlight why these specific outcomes matter for patient longevity.
Okay.
Let's unpack this. Where does the narrative of this particular pharmacological intervention actually begin?
Well, the focal point of the research is the drug Finerenone.
Right. For those familiar with the pharmacological landscape, the source text categorizes this as a nonsteroidal mineralocorticoid receptor antagonist.
Quite a mouthful.
It really is.
Yeah.
But basically, this class of drugs is known for modulating the overactivation of the mineralocorticoid receptor.
Which is a key driver of inflammation and fibrosis in the kidneys and the heart. Right.
Exactly. And Finerenone is already an established entity in the medical community.
Yeah, it has a proven track record. There's robust literature supporting its ability to improve both renal and cardiovascular outcomes.
But, and this is the crucial part, those established improvements have historically been reported specifically in patient cohorts dealing with type 2 diabetes alongside chronic kidney disease.
Right, type 2, which points directly to the critical knowledge gap this trial was trying to fill.
Exactly. Prior to this specific study, the medical community had virtually no concrete data on the efficacy or the safety profile of Finerenone for patients presenting with type 1 diabetes and CKD.
The literature for this specific demographic was essentially a blank slate.
It really was. And the distinction between the two types of diabetes is paramount here. I mean, while they share a nomenclature and some downstream vascular complications, the underlying pathophysiology is entirely different.
Right. Type 1 is an autoimmune condition. It's characterized by an absolute deficiency of insulin.
Whereas type 2 is driven by metabolic syndrome and insulin resistance.
Exactly. Because the systemic environments are so distinct, you cannot simply extrapolate pharmacological success from a type 2 cohort and assume it will mirror perfectly in a type 1 body.
Right, you just can't make that leap.
What's fascinating here is observing the strict, methodical nature of clinical progression. Medical science progresses by taking a treatment that works for one specific population and rigorously testing it to see if it safely applies to another.
Because drug development often tackles the largest patient demographics first.
Yeah, which naturally places a heavy initial focus on type 2 diabetes. When researchers want to expand that indication, they are required to build a completely independent foundation of evidence. They have to design a dedicated, rigorous trial to ensure the intervention is both safe and effective for the new population.
Which brings us to the trial design itself. The researchers constructed a phase 3, randomized, double-blind, placebo-controlled trial to definitively answer these questions.
And looking at the enrollment numbers, they isolated a very focused cohort.
Yeah, exactly. 242 adult participants.
Right. A cohort of 242 is tightly controlled, and the entry criteria outlined in the text reflect a highly selective screening process to ensure the resulting data would be statistically meaningful.
So let's break down who was actually allowed in the trial. The first baseline criterion was an established diagnosis of type 1 diabetes.
Correct. But moving beyond the diabetes diagnosis, they had to quantify the chronic kidney disease. They utilized the estimated glomerular filtration rate, or eGFR.
And the acceptable window for enrollment was an eGFR between 25 and under 90.
Yeah, 25 to under 90 milliliters per minute per 1.73 square meters.
Which sounds incredibly technical.
It does, but we can think of it using a relatable analogy. Think of your kidney as a complex engine filter for your blood.
Okay, an engine filter.
Yeah. The eGFR is basically a measurement of the flow rate. It's how effectively that filter is pushing fluid through.
Got it.
So by excluding patients with an eGFR of 90 or above, they are filtering out individuals with a brand new, perfectly functioning engine filter, or one that's only mildly impaired.
Right, because you wouldn't see a massive drug benefit in a healthy kidney.
Exactly. Conversely, by establishing a floor at 25, they are excluding patients whose filters are completely clogged, those who have progressed to late-stage or end-stage renal disease.
They targeted a demographic with established, moderate to advanced kidney decline.
Which is exactly the stage where a therapeutic intervention might actually alter the long-term trajectory of the organ.
Makes total sense. And the researchers also layered on a third critical requirement regarding albuminuria. Participants needed to present with a urinary albumin-to-creatinine ratio, the UACR, between 200 and under 5,000.
Right. The UACR is a primary biomarker for structural kidney damage.
Back to the filter analogy.
Exactly. If eGFR is the flow rate of the filter, the UACR measures how much good oil is leaking through the cracks into the exhaust.
I see.
Albumin is a protein that should ideally remain in the bloodstream. When the glomeruli, the filtering units of the kidney, become damaged, they allow albumin to slip through into the urine.
So a UACR starting at 200 signifies clinically significant protein leakage or macroalbuminuria.
Yes. While the upper limit of 5,000 caps the severity.
Selecting patients with that specific degree of protein leakage sets a very clear stage for the trial. But there is a methodological detail in the text that is arguably the most important element of the entire study design.
Oh, absolutely.
Every single one of these 242 participants was already receiving an established standard of care baseline treatment.
The text explicitly notes that participants were maintained on either an ACE inhibitor, an angiotensin-converting enzyme inhibitor, or an angiotensin receptor blocker.
An ARB. Because in modern clinical research, especially at the phase 3 level, you simply cannot unethically remove a patient with active chronic kidney disease from a medication known to protect their renal function just to test the novel therapeutic.
You'd be actively harming the patient.
Exactly. The trial must measure the new intervention as an additive therapy. The researchers are essentially asking if Finerenone can provide a compounding benefit on top of a baseline that is already actively managing the disease.
And establishing that baseline is what makes demonstrating efficacy so incredibly difficult. The standard of care drugs are already doing the heavy lifting to reduce pressure in the kidney and limit protein leakage.
Right, so from that optimized baseline, the 242 participants were randomized into two arms.
One arm received the active Finerenone, which was dosed intelligently at either 10 or 20 milligrams daily, tailored specifically to the individual's baseline eGFR.
And the control arm received a matching placebo.
Correct.
The primary endpoint the researchers were hunting for was the relative change in that UACR over a focused 6-month period.
They wanted to track whether adding this specific drug could further reduce the protein leakage compared to optimal standard care alone.
Is 6 months a long enough window?
It is tight, but it is standard for evaluating initial kidney responses and early changes in protein markers before longer-term structural remodeling can be fully assessed.
Okay, got it. Here's where it gets really interesting. The data that emerged at the end of that 6-month window paints a very definitive picture of the drug's capabilities.
It really does.
Let's break down the shift in the UACR metrics.
Looking at the active Finerenone arm, the median UACR at baseline hovered around 574.6.
Okay.
By the end of the 6-month observation period, that median figure had dropped substantially to 373.5.
Wow. A drop of that magnitude is clinically profound. The trial data calculates this as a 34% total decrease in the urinary albumin-to-creatinine ratio for the active group.
34%.
Yeah, seeing a third of the protein leakage resolve over just half a year is a strong initial signal. But adhering to rigorous trial analysis. We have to contextualize that 34% against the performance of the control group.
Right, the placebo group, which remember was still benefiting from their baseline ACE inhibitors or ARBs. They also experienced a shift.
What were their numbers?
Their median UACR started at 506.4 at baseline and eased down to 475.6 at the 6-month mark.
So the control group saw a modest reduction, which the text quantifies as a 12% decrease.
Which perfectly illustrates why the placebo arm is non-negotiable in trial design. Standard of care and other variables still exert an influence over time.
But when researchers compared the two arms directly, the contrast was stark. The data revealed that the addition of Finerenone resulted in a 25% greater reduction in the UACR compared to the placebo alone.
A 25% greater reduction?
Yeah. A 25% relative improvement over an already optimized baseline is a massive clinical victory.
And it's highly statistically significant. The reported p-value was less than 0.001.
For those tracking the biostatistics, a p-value that infinitesimally small essentially eliminates the possibility that this differential was a random occurrence. The drug actively drove that reduction in albuminuria.
And reducing albuminuria is not merely about correcting a number on a lab report.
Right, let's talk about what that actually means for the patient.
The presence of protein leaking into the renal tubules is inherently toxic to the kidney tissue over time. It drives further inflammation and accelerates the progression of fibrosis.
So by effectively lowering the UACR by an additional 25%, the treatment is actively mitigating the cascading damage that leads to end-stage renal failure.
Exactly. I mean, I want you to imagine what a 25% greater reduction in kidney leakage means for the longevity of your organs.
Yeah.
When you look at those numbers through the lens of patient outcomes, the implications are enormous.
Completely life-altering.
For an adult living with type 1 diabetes, whose organs have been exposed to decades of glycemic stress and subsequent vascular complications, finding an intervention that so significantly alleviates the functional burden on the kidneys is huge. It represents a tangible extension of organ viability.
Okay, we see the benefits, but what is the cost? The efficacy data clearly supports the therapeutic hypothesis, but we have to ask the crucial critical thinking question about trade-offs.
Right. A comprehensive analysis of any phase 3 trial must equally scrutinize the tolerability profile.
Because the physiological mechanisms that provide these benefits inherently carry systemic trade-offs that clinicians must manage. Let's look at the adverse events cataloged in the trial text.
The primary safety signal the researchers monitored, which is characteristic of this entire class of medications, is the incidence of hyperkalemia.
Hyperkalemia, which is elevated potassium levels in the blood.
Yes. It's a well-documented risk when utilizing mineralocorticoid receptor antagonists. Because these drugs influence sodium and potassium exchange in the kidneys, potassium retention is a direct pharmacological consequence.
The trial data breaks down the frequency of this adverse event quite clearly. In the Finerenone arm, hyperkalemia was reported in 12 participants.
Out of roughly 121 in that arm.
Right? Given the even split of the 242-person cohort, that translates to an incidence rate of 10.1%.
Contrast that with the placebo arm, where hyperkalemia was noted in only 4 participants.
Which is a 3.3% incidence rate.
So the Finerenone group demonstrated a roughly 3-fold increase in the occurrence of elevated potassium.
A 10.1% incidence rate indicates a very real, measurable side effect that prescribing physicians will have to actively monitor via routine lab panels.
True.
However, the raw incidence rate only tells half the story. The true measure of a drug's safety profile often lies in the severity of those events and whether they force the patient to abandon the therapy.
And the discontinuation data provides crucial context here. Out of the 12 individuals in the active arm who developed hyperkalemia, the text indicates that only 2 participants were required to permanently discontinue the Finerenone treatment as a result.
2 participants out of the entire active cohort equates to a discontinuation rate of just 1.7%.
Which is largely manageable.
It's a remarkably low threshold of failure for the primary adverse event.
It implies that while hyperkalemia is a predictable and somewhat common side effect, the vast majority of cases were mild to moderate.
Meaning, for 10 out of those 12 affected patients, the elevated potassium was likely managed through dietary adjustments, concurrent medication tweaking, or maybe temporary dosing modifications.
Exactly, without needing to completely withdraw the renal protection that Finerenone was providing.
And the ability to manage the primary side effect without losing the primary therapeutic benefit is exactly what clinicians look for when adopting a new protocol.
Absolutely.
But potassium levels weren't the only safety metric scrutinized. We also need to examine the drug's impact on the eGFR flow rate over the course of the trial.
Right, tracking the eGFR is complex when introducing an agent that alters renal dynamics. At the 6-month evaluation, the text outlines that both groups experienced a decline in their estimated filtration rates.
The active Finerenone group recorded a mean eGFR drop of -5.6.
While the placebo group experienced a smaller decline, logging a drop of -2.7.
So comparing the two arms reveals that the Finerenone group experienced a further placebo-adjusted reduction in their eGFR by a margin of -2.9.
And at first glance, a nephrologist tracking a patient's kidney function might view an accelerated drop in the filtration rate as a major red flag.
Right, because the entire goal of the therapy is to preserve kidney function. A metric indicating reduced flow could easily be misinterpreted as the drug causing harm to the filter itself.
That initial concern is common, which is why trial designs incorporate specific phases to differentiate between structural damage and functional shifts.
Oh.
The text provides critical data derived from the post-trial washout period.
The washout period. This is when the active 6-month trial concludes, the participants stop taking the intervention drug, and researchers continue to monitor their biomarkers as the drug is completely clearing from their system.
Yes. And the observation during this washout phase is a vital piece of context. The text explicitly states that once the Finerenone was removed from the system, the eGFR values in the active group approached their initial baseline levels again.
If we connect this to the bigger picture.
Right, if we connect this to the bigger picture, the reversibility of that eGFR decline alters the clinical interpretation completely. This washout data implies the dip in filtration rate is a reversible effect of the drug being in the system rather than permanent damage.
Because if the drug were inherently toxic and causing permanent tissue damage, that -5.6 drop in the filtration rate would remain locked in even after the drug was discontinued.
The functional units would simply be gone. But because the eGFR trajectory rebounded toward the baseline upon washout, it confirms that the initial dip was a benign functional effect.
Meaning it's just the drug doing its job.
Exactly. Finerenone reduces the pressure inside the kidney's filtering units, which is exactly how it decreases the albumin leakage we discussed earlier.
Makes sense. If you lower the pressure in a system, the overall flow rate naturally decreases.
The drop in eGFR is actually a physiological signature that the drug is actively working to relieve mechanical stress on the organ.
It is a functional recalibration, not a pathological decline.
And understanding that distinction is vital for long-term patient management. A physician needs the confidence to see that initial eGFR dip on a lab result and recognize it as a marker of the drug successfully doing its job, rather than a signal to panic and drop the therapy.
Synthesizing all of these moving parts creates a comprehensive profile of a highly effective intervention.
It really does.
Which brings us directly to the core conclusion formalized by the clinical researchers. In a patient population of adults managing type 1 diabetes alongside chronic kidney disease, the administration of Finerenone resulted in a significantly greater decrease in the UACR compared to a placebo.
The trial effectively bridged that historical knowledge gap we talked about.
Right, proving that the renal benefits previously reserved for type 2 patients can indeed be safely extended to the type 1 demographic.
It is a decisive expansion of the therapeutic arsenal for a population that desperately needs advanced, targeted interventions.
So what does this all mean? The true value of diving into the granular data of a phase 3 trial like this is gaining a profound appreciation for the rigor behind modern medicine. Taking the time to understand the rigorous, step-by-step numbers helps us see exactly how medical advancements are proven.
Efficacy isn't determined by theoretical assumptions.
Exactly. It is proven by isolating precise biomarkers, rigorously challenging the intervention against a placebo, and ruthlessly following the statistical reality of the outcomes.
And examining the parameters of this specific trial leaves me contemplating a rather compelling question.
What's that?
Well, we have established that within a highly compressed 6-month timeline, Finerenone drove a massive 34% reduction in structural protein leakage.
Right.
Given the progressive, lifelong nature of diabetic kidney disease, one has to wonder what a multi-year follow-up study would reveal about its long-term ability to protect these patients' kidneys over a lifetime.
That's a huge thought.
If the intervention fundamentally alters the stress on the kidney this rapidly, the cumulative effect of that protection over a patient's lifespan could redefine our entire timeline for the onset of end-stage renal disease in type 1 diabetics.
The potential for long-term organ preservation is a phenomenal avenue for future research to explore. Thank you so much to you, the listener, for joining us on this deep dive. We hope this exploration of the data provided you with a clearer understanding of the clinical mechanisms shaping the future of nephrology. Keep questioning the data, keep exploring the science, and we look forward to having you with us next time.